Welcome to Anatomical Variants Part 2. This is a continuation of the Anatomical Variants Part 1 presentation. We did look at a lot of examples of the foot in Part 1, but we need to look at some more in Part 2, so we'll start with that. And then we'll go on to nutrient vessels, and then take a look at the knee, in particular bipartite patella. And then we'll go on to the pelvis, hand and wrist, elbow, and finish up with the shoulder.
Cleft epiphysis. Cleft epiphysis can appear in many locations. You may find it in the phalanges of both the hands and feet. You may also see it in the distal tibial epiphysis. You can see it in the distal ulnar epiphysis as well. It can be very difficult to tell a cleft epiphysis from a Salter-Harris 3 fracture. Remember, a Salter-Harris 3 fracture is a fracture through the epiphysis. So how can we tell a cleft epiphysis from a fracture? Well, one would hope that the site of pain would be in a different location, and the absence of swelling would also assist. However, sometimes if the site of pain is in the same location, you need to have a follow-up image to be able to identify if it's a fracture, because then it would demonstrate callus formation indicating healing, and if the follow-up image demonstrated no callus formation, that would indicate that this is just a cleft epiphysis. You're not going to get this in your exam, as it's not fair to be able to differentiate between the two. The reason why I've included this in your presentation is so that in future, if you see this, then you can be reassured that if it is not in the site of injury, if there's no pain and swelling, then this is just an anatomical variation. Base of fifth metatarsal apophysis. This, like os subfibulare, is frequently mistaken for a fracture. So, how to tell a base of fifth metatarsal apophysis from a base of fifth fracture? Is quite simple. The apophysis, which is responsible for increase in width in bone and is at the insertion of a tendon, the apophysis runs vertically in relation to the host bone, whilst the fracture runs transversely. Now, it's important to understand that a base of fifth metatarsal apophysis may be multifragmented or bipartite, or originate from a single ossification centre. These are all normal appearances and must not be misconstrued as a fracture. In addition, when the patient is put into a DP oblique position, the diverging ray can create the appearance of the apophysis being much further away from the adjacent host bone than it actually is. This again is a normal appearance. Let's look at this in comparison with some fractures now. Here we have two examples of base of fifth fractures. On the left, we have an adult skeleton. We can clearly see that the fifth metatarsal fracture runs horizontally. On the right, we have an immature skeleton, so we can identify that the base of fifth apophysis runs vertically. In addition, there is an undisplaced transverse fracture that is located in the horizontal plane. So it's important to remember the apophysis runs vertically and fractures run horizontally. On the left, what is it? It's a fracture. Where? Base of fifth metatarsal. How? Undisplaced. On the right, what is it? It's a fracture. Where? Base of fifth metatarsal. How? Undisplaced transverse fracture communicating with the base of fifth apophysis. Talar beaks. These are an exostosis of varying sizes on the anterior surface of the talus. We can clearly see that the cortex of the exostosis is contiguous with the host bone. There's no evidence of a lucent line, no evidence of a breach in the cortex. Therefore, this is not to be misconstrued as a fracture. Where is it? What is it? How is it? No fracture demonstrated. Anatomical variant, talar beak noted. Talar beaks are frequently associated with coalition of the tarsal bones. Let's have a look at a couple of those. The two most common tarsal coalitions are Calcaneal coalition and Calcano-navicular coalition. On the left, we have Calcaneal coalition. The radiographic sign that indicates this underlying coalition is what's known as the C for Charlie sign. If we look, we can see the surface of the talus dome sweeps round and forms a letter C with the sustaculum tali, indicating that there is a coalition of the talus with the calcaneum. On the right, we have what's known as the anteater sign. This anteater sign indicates that there is calcano-navicular coalition, so the calcaneum is coalescing with the navicular. Remember when I said that a talar beak is frequently associated with tarsal coalition? You can see that the surface of the talus, while not forming a true beak, is very prominent. Interestingly as well, there is irregularity to the calcaneal tuberosity at the Achilles tendon insertion, and this is referred to as Haglund's deformity. Haglund's deformity is a retrocalcaneal bursitis and can be very uncomfortable. So, on the left, what, where, how? No fracture. Talocalcaneal coalition demonstrated. On the right, what, where, how? No fracture. Calcano-navicular coalition and Haglund deformity demonstrated. Remember when I said that some anatomical variations can be symptomatic? These are two examples. They can lead to pain and reduced range of movement and general foot dysfunction. That's why it's important not to classify these as normal. The calcaneal epiphysis is still cartilaginous at the age of 5. Most have started to ossify by the age of 7. As they ossify, they can be quite densely sclerotic. They can be very irregular and multi-fragmented, which can be normal. Fusion usually occurs around the age of 12, and nearly all have fused by the time the child is 15. There is a form of calcaneal epiphysitis, i.e. inflammation of the epiphysis, called Server's disease. The important thing to understand is that Server's disease is a clinical diagnosis and that radiographs are normal. So don't worry if you see a multi-fragmented calcaneal epiphysis or if it's densely fragmented. These are normal appearances and should not be misconstrued as fractures. Nutrient vessels are demonstrated in miniature long bones and long bones. They must not be misconstrued as a fracture. So, how can we tell the difference between a nutrient vessel and an undisplaced oblique fracture? Well, nutrient vessels have a smooth course. They have a slightly sclerotic margin. If you see slight sclerosis to the vessel that's communicating with the medullary cavity. They're in a reasonably predictable location. They run diagonally through the cortex, so that the inner limit of the channel lies further than the faster growing outer limit. In the femur, they run away from the knee. In the fingers, they run towards the distal end of the fingers. In the elbow, they run towards the elbow. You only visualize them in profile, so you should never see them in two views. It should not involve the cortex. So the cortex is nice and smooth. There's no disruption. Familiarise yourself by learning to identify them on your hands, your femurs and your elbow views. Bipartite patella. This is a common anatomical variation. Classically, it appears in the superolateral aspect of the patella. We can clearly see there is a dense sclerotic line, indicating that they're well corticated. There is a cartilaginous relationship between the anatomical variation and the host bone of the patella. We can see it again on the lateral here. Sometimes the bipartite has not actually been ossified, so you will see a notch in the superolateral aspect without any adjacent ossification. It's also possible to get tripartite patella, indicating there are 3 pieces, and even multipartite patella. Let's have a look at comparing bipartite patella with a fracture. So on the left we have our bipartite patella. There are well corticated margins, it's smooth, it's round in appearance. Let's compare it with an undisplaced vertical fracture through the patella. There's a sharp, lucent line. Let's have a look now at what it looks like on the axial view. Let's compare the bipartite patella on the left with the vertical fracture on the right. Remember, you must never do an axial view if you have a horizontal fracture running through a patella, because the quadriceps and prepatellar tendon, when the knee goes into flexion, will tear the fracture apart. Equally, if you have a stellate or multi-fragmented patella fracture, you shouldn't do an axial view either, for the similar reasons. But a vertical fracture is acceptable because the quadriceps tendon, as it passes over the patella and feeds down into the prepatellar tendon, will hold the vertical fracture in place and won't tear it apart. So on the left we have the bipartite patella. Dense sclerotic margins, smooth, well corticated, indicating this is a chronic appearance. On the right we have the fracture, sharp, irregular, lucent line, indicating with a break in the cortex, indicating that this is an acute injury. Let's have a look now at our lateral view. So we can see the bipartite patella sitting here. You can see the densely sclerotic margin, indicating it's well corticated, and it's been held in position by that cartilaginous joint. Conversely, because it is a vertical fracture, it's not demonstrated on the lateral view, particularly as there's no displacement. So, what, where, how? No fracture demonstrated. Anatomical variant, bipartite patella. On the right, what is it? It's a fracture. Where? Patella. How? Undisplaced vertical. The ischiopubic synchondrosis is where the pubis and the ischium fuse together. At 11 months of age, this synchondrosis hasn't ossified yet. And it's only once they reach the age of 4 that these synchondroses start to fuse. You can get a slightly bulbous appearance to the ischiopubic synchondrosis, which is completely normal. Let's have a look at another variation. Occasionally, some children have asymmetry to their ischiopubic synchondrosis. Here on the left, we can see that the ischiopubic synchondrosis is quite bulbous in appearance, in comparison to the right. This asymmetry is sometimes referred to as Van Neck-Ohlberg disease. The most important thing is to recognise that this is a normal anatomical variant and should not be misconstrued as an aggressive process such as osteomyelitis or a tumour. So, what is it? Where is it? How? No fracture demonstrated. Anatomical variant. Left ischiopubic synchondrosis. Ozacetabuli is another anatomical variant that is frequently misconstrued as a fracture. That's because it's in a similar location to an avulsion fracture of the anterior inferior iliac spine. So here on the right we can see that the ozacetabuli is well corticated, it's smooth, it's rounded, it has no acute features, it's a chronic appearance. Now let's compare it with an avulsion fracture. So on the left we can see ozacetabuli, smooth, round, well corticated, indicating that this is long-standing, it's a chronic appearance. Let's compare with the image on the right, which demonstrates an avulsion fracture of the right anterior inferior iliac spine. So it's an avulsion at the insertion of the rectus femoris. We can see that the fracture site is irregular, it's sharp. The bone has been torn off due to marked traction of the muscle. So, on the left, what, where, how? No fracture demonstrated. Anatomical variant ozacetabuli. On the right, what is it? Avulsion fracture. Where? Right anterior inferior iliac spine. How? Minimal displacement. Frequently, you can have partial sacralization of L5. On this pelvis view, we can see L5 here. Here's the spinous process. On the right, we can see the transverse process, which is not communicating with the sacrum. On the left, we can see that L5 has sacralized with S1. Occasionally, this can be symptomatic. It's referred to as Berlotti's syndrome. So, what, where, how? No fracture. Anatomical variant. Left-sided sacralization of L5. In the miniature long bones of the hand, the first metacarpal has one epiphysis, which is at the proximal end. The second through to fifth metacarpals have an epiphysis at the distal end, which will eventually develop into the heads of the metacarpals. Occasionally though, you may get a secondary ossification centre. In this particular example, it hasn't come up very clearly, I'm afraid, but there is a secondary ossification centre of the head of the first metacarpal and at the base of the second metacarpal. This is an anatomical variant, and again, you need to familiarise yourself with these locations. If you look, it doesn't look like a fracture. There's a dense sclerotic line marginating the physis. If you compare it with the distal epiphysis, you can see there's well marginated. There's no evidence of a fracture, which will show sharp, irregular breaks in the cortex. These appearances are all chronic, they're long-standing, they're not acute appearing. The pisiform is a sesamoid that sits within the flexor carpi ulnararis tendon. It's the last carpal bone to ossify and may ossify from a multicentric ossification centres. It's important not to confuse these for fractures. Remember, it's quite difficult to fracture your pisiform, so if you see an immature skeleton with multi-fragmented ossification centres in the volar aspect of the wrist, remember it's just a normal ossifying pisiform. Like the foot, carpal coalition occurs in the wrist. The most common carpal coalition is the capito-hamate coalition and the lunotriquetral coalition. Coalitions that occur within the same row, so with the capito-hamate coalition, the coalition has occurred within the distal row, and with the lunotriquetral coalition, this has occurred within the proximal row. These are to be considered a normal anatomical variation. However, carpal coalition that occurs across the rows, for example a capitolunate coalition, that tends to be associated with syndromes. So, on the left, what, where, how, no fracture, anatomical variant, capito-hamate coalition. On the right, what, where, how, no fracture, anatomical variant, lunotriquetral coalition. Epiphyseal spurs are very common, and unfortunately they have a slightly triangular appearance. They're quite sharp, and so they could quite easily be misconstrued for a little fracture. The most important thing is to identify their location, to recognise they are part of the normal physis, to note that there is no associated soft tissue swelling, and to understand that these are normal. Incidentally, there's a fracture through the waist of the scaphoid on the image on the right. Physes may fuse, leaving a residual scar, and these can be quite difficult to differentiate from a undisplaced fracture particularly in elderly osteopenic women. The most important thing is to familiarise yourself with their locations and to recognise that these are a normal anatomical variation. To assist you with elderly patients, look for the soft tissue swelling to assist with your diagnosis. Supracondylar hooks are noted on the anteromedial aspect of the distal humerus. These spurs point inferiorly, and you need to look carefully, and you can identify that the exostosis cortex is contiguous with the host bone. These anatomical variations are seen in less than 1% of the population, and those are frequently of Mediterranean origin. You can sustain a fracture through the supracondylar hook, and this may be associated with radial nerve palsy. Patella Cupid Eye is extremely rare anatomical variation which sits within the triceps brachii tendon. As with all anatomical variants, we're looking for a smooth, rounded, well-corticated margin. There's no associated soft tissue swelling. Let's compare it to the image on the right, where we have an avulsion fracture at the triceps insertion. We can see that the fracture site is sharp, irregular. The adjacent host bone has lost its corticated margin. There's gross soft tissue swelling. Remember, this is extracapsular, so there will be no joint effusion. So, on the left, what, where, how? No fracture. Anatomical variant Patella Cupid Eye. On the right, what is it? Fracture. Where? Left olecranon. How? Comminuted. You can see there's a small little fragments of osseous debris there, and it's distracted as the triceps is pulling on it. Ozacetabuli is an anatomical variant which is located, as you can imagine, at the acromion. We can just see it here on the Gracie view. However, on our axial, we can quite clearly see the margins of Ozacetabuli. We can see that the two opposing cortices are clearly delineated. They're densely sclerotic, indicating that this is a chronic appearance and should not be misconstrued as a fracture. Let's compare it to a fracture, shall we? So on the left we have Ozacetabuli with the densely marked sclerotic margins, and on the right here is our acromion, and we can see the sharp irregular margins. There's loss, there's a break in the cortex, there's a small osseous fragment indicating that it's comminuted, and it's slightly distracted. We can see that the fracture site is a little bit distracted. So on the left, what, where, how? No fracture. Anatomical variant Ozacetabuli. On the right, what is it? Fracture. Where? Acromion. How? convoluted and slightly distracted.